It's been 2 months since the WHO told the world the bad news. Ebola had broken out again in the Democratic Republic of the Congo. And now the latest tragedy. More than 1,000 people have died in this outbreak alone. This time it's killing people at a faster rate than ever before. In West Africa from 2013 to 2016, considered the worst outbreak on record, the buildup was much slower. It took about 8 months to reach 1,000 deaths. And the weekly increase has been rising over time, especially in July. There have been some big jumps, putting this current outbreak on track to become the worst Africa has ever seen. The killer disease has been spreading undetected and rapidly out of sight of the health professionals who are battling to stop the virus.
Medical staff here are on the front line. Mongvalo in Ituri is the Ebola epicenter. They have been working without adequate support, but their commitment remains unwavering. Grace Kakure has been a nurse here for 5 years. Aged 27, she was confronted by Ebola from the very start. It was declared late and the hospital was under-equipped. Grace saw 5 of her colleagues die from the disease, all infected at their workplace. Despite the grief, she stayed.
At the beginning, the epidemic was spreading quietly. The official declaration came after we had already been in contact with patients. What contributed to the infections was our dedication and our care for the sick, because all of those infected were healthcare workers. Even though we lost nurses from this hospital, we've remained resilient. Because if we don't keep going, we'll be sacrificing the lives of others.
Fear of Ebola has even robbed the sick of healthcare. 20 people used to come to the hospital every day, but once the outbreak was declared, they stayed away, fearful that it was the source of the sickening.
After the epidemic arrived here, we noticed some people refusing to come to the hospital, claiming that the epidemic was in the hospital itself. Nevertheless, in recent days, we've seen a slight increase in attendance. People are coming from other areas to receive treatment here. We've got used to it. This is the profession we chose.
About 20 doctors and nurses have already died after contracting Ebola in Ituri province alone. Those who remain feel left behind. Many are not being paid properly. Some died without officially being recognized as public employees in DRC.
This is not a good situation. What we ask of the government is firstly to include us among those who receive hazard pay. Secondly, to remember Mongvalo. Mongvalo has been forgotten by everyone for a very long time.
Despite logistical and financial challenges, the fight against Ebola is continuing on the ground thanks to people like Grace Kakure, who remain committed to serving their community.
To give us some real perspective on this outbreak, Dr. Jean Kaseya joins me, Director General, Africa CDC. Welcome, Dr. Kaseya.
Thank you for having me.
Our pleasure. This is now the fastest Ebola outbreak Africa has ever seen. Why is it proving so persistent? In other words, what's driving the fact that Ebola itself, as you've put it, is now moving faster than the response?
Yes, there are a number of factors that can explain that. The first one is the humanitarian context. You know, we have more than 1,150,000 people living in camps. And these people, for a very long time, they didn't have assistance. And now, when we are coming to talk to them, the second result coming from that is the mistrust. Because they believe that we are just coming because we are afraid of Ebola, and we are not coming to help them. The third reason is insecurity. We are living in a region where rebels are operating. Even my colleagues from Africa CDC who went to a place called Nyakunde were attacked by rebels. The fourth reason is lack of medicine, approved medicine and vaccine. I think all of these reasons combined with the weakness of the health system are explaining this quick spread of the outbreak.
This outbreak is caused by the Bundibugyo strain, for which there is still no approved vaccine. How does that affect your strategy in fighting Ebola? And are there any promising candidate vaccines or therapies that could realistically make a difference?
Having now more than 1,000 deaths is pushing us to rethink about what we need to do. But what is clear is, while we are moving with the clinical trials of medicines and vaccine, and I want to remind you that the clinical trials started a few weeks ago, we are also insisting on what we call the public health measures. And we need for that to rebuild trust with communities. We need them to accept first what we call the dignified and safe barrier. They cannot touch bodies, they have to leave. People who are trained to do that. Second, they have to accept to come to health centers anytime they have symptoms to be tested and to accept to be isolated. And we need them also to be involved on the program, sensitizing communities for this outbreak and to accept that the disease is real. I think these are a number of strategies that we are putting in place to stop this outbreak.
One of the dire challenges is clearly contact tracing. The WHO says 4 in 5 new cases have no known chain of transmission. 4 in 5. To be clear, that means the virus is spreading where health officials are not looking or can't even see. In simple terms, what are the implications of that, and what, if anything, is being done to fix it? I assume this has a lot to do with the fact that this virus is happening in a conflict zone.
You know, when I started to talk about the contact tracing issue, some people were shocked. Just to give the clear information on what is going on, when we have more than 2,600 cases, confirmed cases, you are expecting around 92,000 people in the contact list. Because for each confirmed case, we have 40 people in the contact list. Currently, out of this, let's even say 90,000, we just have around 12,000 people in the contact list. This is why one of the consequences you are saying, more than 60 to 70% of new cases are coming from community, are not coming from the contact list. We cannot say we'll have a total understanding of the outbreak, even the control of the outbreak, if we still have cases coming from the community and not from the contact list. This is the major challenge that we have currently.
Our viewers just met Grace Kakure in Mongboala, a nurse who works there. She has lost colleagues, works in an under-equipped hospital where colleagues haven't received hazard pay. This is against the backdrop of attacks on public health teams. Dozens of health workers have already died in this outbreak, as you well know. What is Africa CDC doing to support and protect frontline staff like her?
Yeah, this is a critical question because we cannot afford to have health workers dying during an outbreak because we need them to respond to the outbreak. Unfortunately, we have more than 120 of them already affected, and we lost more than 36 health workers. What it means? It means we, Africa CDC, WHO, and other partners, we need to intensify what we call infection prevention control. We need to equip and nurses and health workers. It was not the case in the beginning. This is when we had so many of them affected. and infected. But currently, we increase our capacity to equip health workers, and I think we are protecting them more than it was before.
Doctor, let's turn to treatment. We've seen U.S. Health workers brought here to Germany for novel treatments using antibodies and retroviral drugs. They were helped enormously. 7 current monoclonal antibody therapies transformed treatment for the Zaire strain of Ebola. How significant has this breakthrough been for patient survival and outbreak response with that variant?
You know, it's really unfortunate after 19 years of this Bundibugyo virus, it's just now that we are conducting clinical trials to know if there is a treatment. Also, African people, they are seeing what's happening. When there is an American infected, they will send him in Germany to get appropriate care. But, you know, what we are saying is we are learning from that. And we'll continue with our clinical trials. We have 2 drugs that we are combining. And these 2 drugs will give us, in a few weeks, critical information on the efficacy of the treatment. We hope to say to our people in Africa, before the end of this year, that we find a medicine that can cure Bundibugyo. That was not the case in the past. Regarding other solutions that other countries they have, we are talking to them. We are asking for solidarity, and I hope they will understand also our message, because it's time for us to work together.
Could candidates such as these monoclonal antibodies mark the beginning of a new generation of broad-spectrum Ebola therapies effective against multiple Ebola species?
Yes, we hope to have, you know, like now for diagnostics, we have platforms that can help us to detect 5 strains at the same time. We are hoping also to have a drug that can help us to respond to Zaire strain, Bundibugyo strain, Sudan strain. But for now, we don't have. For now, we are hoping that the monoclonal body that we have, and also the remdesivir that we are using to as a clinical trial, we hope that by combining both, we can have a treatment. We will see if this treatment can also respond to other strains.
Dr. Jean Kaseya, appreciate your making time in what I suspect is a busy schedule. Best of luck.
Thank you so much. As you know, I also sent a letter to the US government to lift the travel restriction to Uganda, and I hope, because Uganda did great progress, I hope they will do that. We are counting on that Deutsche Welle for them to listen from this message and to say they have to act.
We'll be watching developments. Thanks again.
Thank you.
Alongside those healthcare workers, there are, of course, other members of the community who are struggling, parents who've lost children, and the children, of course, who've survived. Joined now by Dr. Babu Rukungeza, Save the Children's Ebola response lead in the DRC. Doctor, welcome to DW News Africa.
Thank you, Michael. Yeah.
Our pleasure. Your data now shows 189 children dead. That's about a fifth of all confirmed deaths. That rough percentage has held steady since the early weeks of this outbreak. Why do children keep dying at roughly 1 in 5? Are those rates you would expect given the ratio of children to adults in the affected areas? Or does something else explain this?
Let's say, thank you for this question. Currently, we didn't expect to have this high number of children dying, and the case fatality is still very high among children. And this maybe can be explained by the fast spreading of this outbreak, Bujubuju virus, currently happening in DRC, affecting 5 provinces and mainly here in Ituri. And yeah, we are also surprised to see this high number, and among of them we have children who are really dying. This is something really unprecedented. If we have to compare to previous outbreak, we didn't see a lot of children dying for this outbreak like this for now.
As far as you can see, and I know that you are not, you're not studying the strain per se, you are part of the response team. Is this particular strain somehow are children much more susceptible to this particular strain, or is that something that you're just not sure of yet?
No, for this strain of virus, it's very new, and it seems that children are really, let's say, the many. They are among the many people who are really infected. Maybe this is because of the strain of Bujubuju. As we can see, the sign and symptom is close to malaria or to typhoid, and this leading the misdiagnosis. And also we have a lot of malaria, we have a lot of typhoid. This is one thing. The second thing, children are really close to the adults. When adults is healed, the children who is be there to provide maybe water, maybe to help, they are close to their families, and then it's where they are getting infected. And also, as many disease for children, we have fever, and we have other symptoms like vomiting. And people are relying on this is a normal disease, but when they arrive at the hospital, it's too late, and it's why we have a lot of children getting this disease.
Doctor, tell me something. What does trauma look like in a 5 or 6-year-old who's lost a parent to Ebola? And is it any different from what you'd see after any other kind of loss?
No, yeah, it's really, this is really what we are seeing. It's really dramatic. It's really when you are seeing all those children with fear, developing isolation, social withdrawal, and even persistent crying or frequent crying, fatigue, irritability. We are noticing all those symptoms when we are getting all those children in our mobile or fixed chat-friendly space, and we are noticed that, and we have our psychologists to support them. Even we are trained our partner on a psychological first aid to support all those children, because the weaknesses, and they saw their parent, they saw their brother, they saw their sister, uncle, aunt dying. And this is something we need really to support all the survivor children during this 17th outbreak of Bujubuju here in Bunia, Ituri, or in DRC.
So children are avoiding close contact. They're keeping physical distance from each other and adults. Is that a healthy protective instinct, or a sign the disease is reshaping childhood itself in Ituri province?
Yeah, that this is really the situation that we are facing in Turi. For now, we are trying to work hard on RCCE, risk communication and community engagement, to involve community leaders, to involve parents, and also we are working at the school level just to spread the right message, how we can prevent, how we can protect our children to not get infected. All those things we are trying to put them on place to prevent any disease for the children. is still very, let's say, difficult because we have some resistance because some people or some part of the population don't believe that this outbreak is really. But we are struggling with that, but also we are pushing. And I think we will get the right result because we are trying now to diversify our canal of information using community leaders, using churches, using all those religious leaders just to spread the right message. Even we are working with the group of children or group of young people for them to let them know about how to protect themselves against this disease here in Ituri.
I understand that you're calling on the international community to fund child protection and mental health support, not just the medical response. Where are you seeing most of the gap in funding? And if you don't get that funding, say by the start of the next school year, what's the outcome you're most worried about?
Yeah, for sure. No, Save the Children and all humanitarian partner and the international NGO we advocate to have flexible and timely funding for this response, and particularly to integrate fully the MHPSS, mental health, psychosocial support in this response. It's already there in the national response plan. Now we are trying to roll out all those activities, and for sure this plan and all those activities need funding, and it's why we call for the international community to support this outbreak, because without that we will continue to face many problems, even for next generation. Let's say they will continue to face those problems. And I think for me, mental health, this is really the time to be integrated in the response, but even beyond that, it must be integrated in the primary healthcare services where we can provide all those services, because it's really incredible what we are notice here, what we are witness here. We need people here need really these services in terms of MHPSS services here, and for sure we need also international support for us to implement all those things on
Doctor,
the ground.
just for a moment, take me inside the community. You are with children, actual individual children that you've gotten to know. Let's imagine that that you don't get the international funding that you're looking for. Tell me how the life of an individual child is different tomorrow or next year as a result of not getting that funding.
Yeah, imagine in the small house here in Bunia or around Bunia, you see a child who don't have access to the basic services like health services, education services, even protection, and this child is a high risk for sure to be really infected, but also already have their parents. He lost their parents, who is the main let's say support for him, and these children will be in the road, let's say in the streets, begging or something like that. This could be one of the situation. The second things, those children could go to the mining or the mineral sites just to see how they could survive having those minerals. Or those children could also be, let's say, recruited in those armed groups. Just look here in eastern part of Congo, as you know, we are facing humanitarian crisis, but we still have also a lot of armed group here in Ituri and surround Bunia. And I think without a strong commitment to stop all those fighting or to stop all those armed groups, and if we can have support for those children for their future, I think this is where our fight will start, just to provide a safe environment for those children for their future. Going to school, doing those small things, having the time to go play with other and learning education. This is the things that we need really to provide for all those children. Without the support, and I think we can lose maybe those children, even a generation of children here in Turi.
Dr. Babu Rukungeza from Save the Children, many thanks.
Thank you.